I think we can start. So,
hello, everybody.
Yes, hello, everyone. I'm very happy to welcome, to host you again to our seventh live broadcast DxBone forum. So you know probably that this is a platform for education that we have developed a few weeks ago with the COVID, I would say, break the lockdown. And for that reason, we decided to provide some education to our colleague surgeon, doctor, physiotherapist, nurse, and to discuss about different topics in orthopedic and sport medicine. This live broadcast will be available at any time in our DxBone channel, so you can register if you want, subscribe, and you will be able to see that in the future if you don't have time, because now people start to go back to the normal work. And I'm very happy to host and to welcome our colleague, Dr. Thierry Monfils, for this topic today, which is the Piriformis syndrome. It's probably a syndrome that few of you are knowing very well with experience. Thierry has a large experience on this topic, not only this one, and I'm happy that you will provide us your experience and expertise about this syndrome with all the differential diagnosis. So Thierry, if you want to share your screen, the microphone is yours.
Perfect. Thank you very much for this kind introduction. My presentation is about the Piriformis syndrome. More widely, Piriformis syndrome is to be considered as part of the deep gluteal syndrome, and could also be considered as the equivalent in the pelvis to the Thoracic Outlet Syndrome. That's what I will try a little bit to show you in this topic. The first description that has been made in 1928, but the name has been given in 1947 by Robinson, and since then many other causes have been discovered, because for a long time the only considered cause was the piriformis muscles. So the other cause has been grouped under the name deep gluteal syndrome, even if the other names do exist in the literature, like pelvic outlet syndrome or infra-piriformis foramen. Just remind during this topic that when we speak about the piriformis syndrome, we always speak about pain in the buttock and radicular pain. So this piriformis syndrome has been controversial and confusing quite since the beginning. More than 27% of the physical medicine and rehabilitation specialists in the United States do not believe that PS exists. This PS is confusing. Some authors think that it's overdiagnosis, others that it's underdiagnosed, and probably because there is two very big difficulties in this PS. First, there is multiple responsible factors of sciatic nerve entrapment in the buttock, and second, the differential diagnosis of buttock pain, sciatica and sciatica-like pain is very, very large. So this confusion leads to multiple investigation, to multiple consultation related to this misdiagnosed pathology. So same for the incidence, from 0.3% to 17% of sciatica, including the radiculopathy, 0.7 to 1.6% of all the low back pain. So this is a very variable incidence according to the definition and the selection methods. And even if you consider that this PS is as common as discogenic sciatica. So what is really clear is that the true incidence is not clear at all. So for the anatomy, just a kind reminder, of the limits of this deep gluteal space, limited posteriorly by this gluteus maximus muscles, anteriorly by the coxofemoral joint and the proximal femur, medially by this sacrotuberous ligaments you see a little bit here, the linea aspera laterally, superiorly here the inferior margin of the greater sciatic notch, and inferiorly the distal ischiatic border and the hamstring origin. What's the content of this space? It's muscles, it's ligaments, and it's nerves. For the muscles, for sure, there is the piriformis muscles here, but there is also the other external rotator muscles below, gemellus, obturator internus, and quadratus femoris. For the ligaments, the two more important are the sacrotuberous here and the sacrospinous ligaments. For the nerves, more than the sciatic nerve you see here, there is other nerves in this space, the superior gluteal, the inferior gluteal, the posterior femoral cutaneous, the pudendal, and branches for the other external rotator muscles. For sure, there is the piriformis muscles that is centrally positioned in this buttock. This muscle is inserted on the anterior sacrum, going through the greater sciatic notch to insert on the greater trochanter. This PM is an external rotator when the hip is extended, but is also, and it's important, an abductor when the hip is flexed. For the patient, the sciatic nerve is, the piriformis muscle, is stretched when the patient is sitting, and mostly when is sitting with the legs crossed. For the sciatic nerve, there is some characteristic that you should know for this topic. First, the fibers of the common peroneal branch and the posterior tibial branch of the sciatic nerve are still separated in the proximal sciatic nerve. This explaining the distribution of the symptom in the clinical neurological examination in the extremity in case of sciatic nerve entrapment. The sciatic nerve is anterior to the piriformis, but posterior to the other external rotator, explaining a possible seesaw effect between the PM and the other external rotator. And finally, this sciatic nerve is able to accommodate to motion because it can move by stretching and gliding. So now, what are the possible causes of sciatic nerve entrapment in this deep gluteal space? The most frequent is obviously the piriformis syndrome. Why? Because some suspected anatomical variation of the relationship between the PM and the sciatic nerve to be the cause. There is many possible variation described first by Beaton in 1938, knowing that the type 1 here over, which is the normal position of the sciatic nerve, and the type 2 when the common peroneal nerve is going through the piriformis muscles are the two more frequent. Together they represent more than 95%. But are those variation possible cause? It's absolutely not sure. Why? Because the prevalence of those abnormal variation is quite the same in asymptomatic patient when you do cadaveric studies and in symptomatic PS patient. What is clear is that overuse of the PM is a cause by hypertrophy, by spasm of the PM, compressing the sciatic nerve because of hyperlordosis, because of coxofemoral anti or retroversion, because of some activities, long activities like running. There is also, and I told you before, the seesaw effect between PM and other external rotator, the long sitting position for sure, especially crossed legs position with this hip flexion and abduction position. And if you add to this sitting position the internal rotation position of the hip, you have the fair position, flexion, abduction, internal rotation, stretching the PM, narrowing the space between the PM and the sacrotuberous ligament, so possibly compressing the sciatic nerve. You can also have a direct or an indirect PM damage by contusion or by excessive stretching, sudden stretching during some activities. Now, I told you there is PS, but there is also other cause of compression of the sciatic nerve in this deep gluteal space. What are those causes? Possible fibrous bands with a possible ischemic neuropathy of the sciatic nerve, gluteal muscle atrophy with a lack of protection of this muscle on the sciatic nerve. You can have a proximal hamstring muscle injury, accidental or by overuse with tendinopathy. I told you about this gemellus OI complex seesaw effect with the PM. You can have also a cause in the ischial tuberosity with fracture, malunion, the so-called ischial tunnel syndrome with narrowing of the space between the ischial tuberosity, the hamstring, and the quadratus femoris. A little bit the same, the ischiofemoral impingement, narrowing the space between IT and the femur space, and other vascular abnormalities. Other cause the space occupying lesion in the DGS, for example, tumor able to compress the sciatic nerve, or specific cause like prolonged surgery in seated position, like acetabular reconstruction, like total hip arthroplasty, like coxofemoral hyperlaxity, anteretroversion, fracture, trauma, and others. So we saw the etiology, the possible causes of the PS. We saw the possible cause of the other deep gluteal syndrome. Now, what are the possible causes of sciatica or sciatica-like pain and buttock pain out of this DGS, this deep gluteal space? If you have a sciatica or a sciatica-like pain, you have to consider possible radiculopathy L5, S1 because of discal herniation, because also of a possible Tarlov cyst you can see here on the MRI, or because of a lumbar canal stenosis here on this picture, this coda equina syndrome. You can have other neuropathies, proximally, pudendal, gluteal, or posterior femoral cutaneous neuropathy, or distally, the branch of the sciatic nerve, the tibial and the peroneal branch. And you can have a fake sciatica, the pseudo sciatica related to facial joint derangement. Never forget the multiple sclerosis that can mimic at the beginning of this disease a sciatica. So other causes, non-DGS causes, but of deep gluteal pain, buttock pain, consider possible intrapelvic lesion, consider a possible fracture of the pelvis, sacroiliac joint disturbance, cluneal nerve impingement, also this nerve coming from the upper lumbar spine and giving innervation of the buttock, hip derangement, trochanteric bursitis, sacrococcygeal derangement. So now we saw there is a lot of possible causes of pelvic piriformis syndrome, of deep gluteal syndrome, or other causes coming from out of this space. What can we have at the clinic assessment helping us to go out of this differential diagnosis? So what are the characteristics of the PS at clinical assessment? What are the difference when you have an other DGS cause? What are the difference when you have cause out of this deep gluteal space, causes of buttock pain or causes of sciatica or sciatica-like pain? For the PS specific clinical assessment at history taking, you can frequently have a trauma with a PM damage. You should have deep gluteal pain with burning sensation, with radiation to the posterior thigh or posterior calf, but never forget that in PS, the buttock pain should dominate the low back pain. This pain is increased characteristically at long sitting, at long driving, could be also related to overuse, the long running, long cycling, long rowing, and more than the buttock pain the PS should include sciatica-like pain. For this sciatica-like pain, it's mostly numbness and paresthesia in the extremity. Rarely you will have motor sensory deficit. Why? Because of the pathophysiology of the sciatic nerve impingement. This is related to transient, dynamic, repetitive compression of the sciatic nerve. So it's mostly demyelination that you will see in the sciatic nerve more than real axonal lesion of this nerve. At observation of your patient entering in your clinic, you can see this situation with the right hip external rotation because of, in this involved buttock, the piriformis muscle spasm. And this piriformis muscle spasm, you will see it also when the patient is laying on the table with this tonic hip external rotation. You can see leg length discrepancy, you can see hyperlordosis that are possible causative factor. You can see a sacral rotation toward the opposite side because of this piriformis spasm. And you can see this sitting position, a little bit weird, the patient avoiding to put pressure on this painful spasm of the piriformis muscles. When you check the range of motion, you can have a limitation of internal rotation of the hip. And more specifically, you will have this restriction of flexion, adduction, internal rotation, the fair position described by Solheim. At palpation, you frequently will palpate this spasmatic muscle, painful muscle in the sciatic notch. A little bit difficult in case of obesity. For the neurologic examination, I never use the LASEG or the SLA test because of the poor specificity of this test for the differential diagnosis at least. And I told you there is rarely motor sensory and reflex testing deficit because of the pathophysiology of the sciatic nerve impingement. If you have some deficit in the muscle, it will be in the distal muscle with a non-specific distribution, so not specific radicular distribution L5 or S1, and not a pure specific distribution of common peroneal or tibial neuropathy. So with this clinical assessment, many times the diagnostic will be confusing. It remains an exclusion diagnosis, this PS. So along the story of this PS, many authors describe many specific tests using stretching of the PM or contraction of these piriformis muscles. For the most useful stretching test, there is the Freiberg test, here described, patient supine with maximal internal rotation adduction. There is the FAIR test idea I talked about previously, flexion, adduction, internal rotation, patient supine or patient prone, adduction, internal rotation passively, the palm test. The TGCL test described by Michel, using this concept developed by Delp that the PM is stretched in external rotation when the hip is flexed more than 90 degrees. For the active contraction test of the PM now, the most useful are the pace test, here with the patient seated, knee flexed more than 90 degrees and exerting a manually resisted hip abduction. The BT's test, patient side lying with hip and knee flexed and with a manually resisted abduction, external rotation contracting the piriformis muscles. Now the FAIR test, but the active FAIR test developed by Fishman, patient side lying in fair position and asking this patient to do a flexion, external rotation and abduction. So for myself, I use the association described by Michel using the Freiberg, the passive FAIR Solheim test, the TGCL and the BT's test with a good sensitivity, a good specificity. And if I want to have more specificity, I use also the active Fishman FAIR test, the PACE and the palm test. And I told you I never use the LASEG test. Another tool that Michel gave us is this diagnostic criteria list you can see on the right side of the slide with 12 criteria. If you have 8 criteria positive on 12, the diagnosis of PS is quite sure with a good sensitivity and good specificity. So now that we saw the clinical assessment of the specific Piriformis syndrome, what are the differences with the other DGS cause of sciatic nerve entrapment? Logically, the Michel's criteria should be less than 8, but never forget and be careful. Many of the 12 criteria are compatible with every causes of sciatic nerve entrapment. What are the positive symptoms at history taking? If you have a sudden onset of pain at ischial area after a sudden movement, think about hamstring injury. If at history there is accident, fall, road traffic accident, a suspected fracture, hematoma, or something else. If the pain is mostly at ischial tuberosity, think about hamstring tendinopathy. Now, if the pain is more mechanical than postural, like in the PS, you can think about fracture, avulsion, and tendinopathy. If at history taking you have this red flag, recent abnormal weight loosening without explanation, you have to consider a possible neoplasm. And never forget a possible previous pelvic or hip surgery, previous intragluteal injection that are possible cause of sciatic nerve entrapment. Now, at clinical examination of this other cause of sciatic nerve entrapment in the deep gluteal space, you shouldn't have this tonic external rotation. Even you can have the patient coming walking in an internal rotation in case of femoral anteversion. So if you have pain at the ischial tuberosity, think about the hamstring injury and do the resisted testing and the stretch testing, the Puranen-Orava test, the bent knee stretch test, and eventually the taking of the shoe test. You can use other specific tests, pelvic bone percussion, searching for fracture, searching for stress fracture, palpate for an eventual tumor in the buttock, check an eventual coxofemoral hyperlaxity, and if you suspect an ischiofemoral impingement, do this ischiofemoral impingement test with passive extension, adduction, external rotation, or do the long stride walking test, asking your patient to walk with a very large step. Now, if we consider the non-DGS causes of gluteal pain, so buttock pain, but originated out of the deep gluteal space. In that case, the Michel's criteria will be negative, less than 8, even less than 6. At history taking, you can have gynecological clues, you can have pain at the sacroiliac, inflammatory like in the ankylosing spondylitis, or more mechanical. If you have a trauma, suspect a pelvic fracture or sacrococcygeal dislocation. If you also have pain at the groin, if you have morning stiffness less than 60 minutes, if the pain is more mechanical than postural, consider an eventual hip derangement. If you have lateral or posterior pain, consider bursitis of the trochanter or coccygodynia. Now, a clinical examination of those non-DGS cause of gluteal pain, you have to palpate the pelvis, the trochanter, the coccyx, and you can use specific tests like, again, this bone percussion test for fracture, and for the sacroiliac joint, the specific test, the thigh thrust test, the Gansland test, the sacroiliac compression and distraction test, and the sacral test. If now you suspect a hip derangement, the fair passive test could be positive, but more on a mechanical mode than on a postural mode, like in the PS. And you can also use the Faber test, and you have to check an eventual mechanical restricted range of motion, especially in internal rotation. Now, for the non-DGS sciatica or sciatica-like pain. Also, the Michel's criteria will be negative, less than 8, less than 6. At history taking, in that case, the low back pain should dominate the buttock pain. If you have pain at the upper lumbar spine, think at this cluneal neuropathy. If you have perineal sensory, urinary, sphincter, sexual disturbance, consider pudendal neuropathy and the coda equina syndrome. If you have sensory disturbance at the posterior thigh, consider posterior femoral cutaneous neuropathy. Now, if the patient complains of sciatica-like pain, but not below the knee and without numbness, you have absolutely to evoke a possible facet syndrome. If the patient complains of pain at walking but decreasing rapidly at sitting, it's an indication of coda equina syndrome. And if the Valsalva test is positive, evoke the discogenic sciatica. Now, at clinical examination of those non-DGS cause of sciatica or sciatica-like pain. I told you, if you have a drop foot, probably it's not a PS, Piriformis syndrome. It's more likely a common peroneal neuropathy or L5 radiculopathy. If at palpation there is pain at the posterior iliac crest, it could be a cluneal neuropathy. Now, you have to do a very cautious neurologic examination of the extremity. And if you have a specific distribution of the radicular L5 or S1 neuropathy, a radiculopathy, if you have something that is specific of a common peroneal or posterior tibial distribution, think about those causes. If you have medius and minimus gluteal weakness, it could be a superior gluteal neuropathy. Now, if at this cautious neurologic examination, you have something a little bit confusing, mixing peripheral and central deficit mixing symptoms of sciatic nerve and other nerves, you have to evoke a multiple sclerosis. You can finally use two specific tests, one for the sacroiliac joint, a seated extension rotation test, and one for the discogenic sciatica, the slump test. Now, this clinical examination can give you a bundle of clues about the PS, about the DGS, about the non-DGS causes of buttock pain, of sciatica and sciatica-like pain. But many times, the diagnosis will remain confusing after clinical examination. So is imaging and complementary investigation able to give you information to go out of this confusion and this differential diagnosis? The most useful test you can use is the ultrasound. This ultrasound can give you information about PM, piriformis muscle, and sciatic nerve enlargement, even if there is no consensus about this. This enlargement could be bilateral. It's difficult to assess in case of obesity, but has the advantage to show dynamic change in the piriformis and sciatic nerve relationship. This ultrasound can also show you gluteus maximus atrophy, and nowadays we use the high resolution ultrasound that is more reliable. I will talk a little bit later about ultrasound-guided diagnostic injection. Less available but more accurate is the MRI that can show us congestion around the sciatic nerve or change in the relation between PM and SN. And now we use specific sequences, the MRI neurography, that can show us sciatic nerve anatomic details and abnormalities, like in this picture here, where you see the left sciatica that doesn't have the same aspect than the right sciatica. So this association of many sequences of MRI, MRN have a good specificity and sensitivity confirmed by surgical decompression result. Now, this MRI gives you a picture of the relationship between PM and SN and eventual modification of the structure of the SN. But is this picture related to the function and the dysfunction of the sciatic nerve that you observed at the clinical examination? the MRI will not give you this information. So is ENMG able to give this affirmation of the relation? EMG, which is the recording of the muscle electrical activity with an electrode and able to show you denervation sign in case of denervation, is rarely positive and always for the same pathophysiological reason of the entrapment. But if you have denervation, it will be more commonly in the common peroneal than in the posterior tibial fibers. And you will not have denervation, never, in the paravertebral and gluteal denervation, which are innervated by branches emerging before the piriformis muscles. Now, I told you the pathophysiology of the sciatic nerve gives more demyelination of the sciatic nerve. So is it possible to assess this conduction slowing of the sciatic nerve focally with nerve conduction studies? The only useful test is the H reflex. You can see here this H reflex by stimulation of the sensory fibers of the sciatic nerve here at the knee, eliciting this reflex loop crossing the spinal cord and giving this contraction here in the sural muscle recorded with surface electrode. So unfortunately, this H reflex is not useful in the normal resting position. So Fishman developed the fair test H reflex. So the same H reflex, but in the fair position, increasing the compression of the sciatic nerve under the piriformis muscle. So increasing the reduction of the velocity in the sciatic nerve and delaying the H reflex. So he showed that a difference of more than 1.86 milliseconds comparing the rest H reflex to the fair H reflex is indicative of PS with a good sensibility and specificity. This has been confirmed by some authors, a little bit less by other authors, but my master in NMG, Dr. François Wang and my Dr. Tomasella did a study that confirmed that a difference right-left of more than 0.5 milliseconds at the fair test is indicative of a piriformis syndrome. In conclusion, for the investigation of the PS, I will recommend ultrasound and ENMG as first step investigation for the PS, MRN and ENMG for follow-up over the time of the PS, knowing that ultrasound, MRN and ENMG requires absolutely a high technical expertise to be accurate. Now, what about the imaging and complementary investigation for the other DGS causes of sciatic nerve entrapment? X-ray can show you fracture, leg length discrepancy, hyperlordosis, increased sacral slope. Ultrasound can show you gluteal atrophy, hamstring injury, and use ultrasound guided diagnostic injection will be helpful for some diagnosis like this ischiofemoral impingement syndrome, or for the gemellus OI scissor effect also. MRI will be helpful in case of fracture, or showing you the ischiofemoral gap narrowing, showing you coxofemoral version and these abnormal vascular issues. If you suspect now a non-DGS cause of a sciatica, if you suspect a radiculopathy, you will order a spine MRI, searching for different cause of impingement of the radiculopathy L5S1. And you will order an EMG. And in this case, you will have abnormalities and denervation in the proximal muscle, paravertebral and gluteus, medius minimus. This EMG should be used also for the other neuropathies like the distal sciatic nerve, tibial and common peroneal, for the pudendal nerve, for the gluteal nerve, for the posterior femoral cutaneous nerve. Also, the ultrasound-guided injection or fluoro-guided diagnostic injection will be used to assess the diagnostic of facetogenic buttock pain, of cluneal neuropathy, of pudendal neuropathy, and of the posterior femoral cutaneous neuropathy. Now, if you suspect a multiple sclerosis with the clinical assessment and the story, for sure, as for a puncture and analysis and a brain MRI, that will confirm this diagnosis. Now, for the non-DGS cause of buttock pain, if it's a sacroiliac joint, do an MRI that will show you inflammation in sacroiliitis or degeneration in osteoarthritis. If it's an hip osteoarthritis with a severe osteoarthritis, X-ray will be diagnostic. With the beginning of osteoarthritis, the CT scan will be more specific and sensitive. For labral lesion suspicion, do an MRI or an arthro CT scan. If it's an intrapelvic issue, do ultrasound and MRI, and use this ultrasound and guided injection for the trochanteric bursitis. Now, some words to finish this presentation about the specific treatment of the PS, because here there do exist a consensus on the treatment algorithm. The first step treatment should be the conservative treatment with physiotherapy and medication. In case of failure after 6 weeks, you can use ultrasound guided injection. In case of failure after 1 to 3 injections, you can use botulinum toxin injection. And only in case of failure of those 3 first steps, you should consider surgical decompression and neurolysis. For the conservative treatment of the specific PS, you should consider the cause. If it's an overuse, you should educate the patient, stopping the triggering activities, changing the rest position and others. For the nerve entrapment, using anti-inflammatory, vitamin B, gabapentin and pregabalin for the neuropathic pain. For the piriformis spasm, you can use muscle relaxant medication. You can use physical therapy techniques like different techniques of stretching, relaxing deep massage, and extending those techniques to neighboring muscle like hamstring. Never forget to do hip motion and to do eventually sciatic nerve motion, gliding motion, and also use the manual therapy, osteopathy as checkup and also as reharmonization locally and distally. Now for the therapeutic injection, you can use anesthetic and corticoid, always under ultrasound guidance for the sciatic nerve safety and also for efficiency, even if this efficiency is a little bit different in different studies. There is one consensus telling that the first injection should be an anesthetic injection because anesthetic could confirm the diagnosis, and also because anesthetic injection only is frequently as efficient as anesthetic and cortisone. In case of failure, you can use botulinum toxin that has been shown to be more efficient than other injection, even if there is other side effect. For the surgical decompression, more than open technique now, we use the mini-open tenotomy or the endoscopic tenotomy or neurolysis with a very good success rate. Fishman talking about 80% success rate on the 20% failure or the 3 first treatment. Thank you.
Thank you, Thierry. It was great, and it showed that this syndrome, which is probably not very known by the majority of people, just illustrate that there are multiple causes of buttock pain and sciatica and all why this piriformis muscle syndrome is so famous. I mean, why do we talk more about this one? You see what I mean? Than other.
I think there is two.
Do we have? Is it because we didn't know before?
I think there is two different reasons. First, it was the first described cause of entrapment of sciatic nerve that is not coming from the spine. When you have a sciatica pain, the first thing you have to think about is for sure the radiculopathy. But many times, when you have a radiculopathy, you ask for an MRI, and this MRI is not contributing. You have to know that only 15% of the MRI are positive in case of radiculopathy. So in that case, you have to search a little bit further. And the first described cause was the piriformis muscle. So that's the first reason. The second reason is that out of the radiculopathy, the most frequent reason remains the piriformis muscle in the different studies. We talk about 2 to 1/3 ratio of the piriformis cause.
So it's a frequent pathology, more frequent than we could imagine.
I think yes. I think yes. I
mean,
that
something that we need to have
this association, sciatica pain, buttock pain, and the MRI is not contributive. You should think about this syndrome, I think. And you have to do this differential diagnosis. And it's maybe another reason why it's a little bit so famous, because the differential diagnosis is not easy to do. There's multiple causes, and the differential diagnosis is sometimes difficult, because I didn't talk about one differential diagnosis is the most difficult to assess. It's what we call the double crush syndrome. What is double crush? The best example is to have association of sciatic nerve lesion in the spine, radiculopathy L5, for example, and a second lesion on the sciatic nerve under the piriformis. So it's a double lesion of the sciatic nerve at 2 levels, and it's very difficult to assess this, even by NMG.
And you mentioned already, but just to confirm, when there is a piriformis syndrome, there is one of the 2 signs, which is buttock pain and sciatica. But can we have, you told us, but it's important, can we have, can it be a cause of drop foot without pain?
Usually the pure piriformis syndrome, you should have buttock pain, and you should have sciatica-like pain. Rarely drop foot, because it's more demyelination than axonal loss. But I think that if you have a drop foot without pain, you should think first about common peroneal neuropathy at the fibril head. Secondly, the radiculopathy L5, and if there is not contribution of the MRI for the spinal and the NMG, because the NMG will be diagnosis for the common peroneal nerve. So do an AMG, negative, do an MRI of the spine. If both are negative, think about buttock pain.
And one thing you mentioned very clearly, it's interesting because actually I didn't remember that. When you said that the patient, when he's standing, the first thing when you look at the patient, he's standing in the external rotation.
Yeah.
So you said that it could be a contracture.
Yes.
Could it be as well the fact that, you know, if you are in internal rotation, you compress a little bit because you put in passive tension. So could it be a sort of reaction to untie and to release the sciatic?
So logically, in case of piriformis syndrome, and only in piriformis syndrome, this external rotation you can see in your patient in the involved side is related to the contracture. The contracture of PM gives this unilateral external rotation. Now, is it a reaction? For sure, if your piriformis muscle is painful, you will try to be in external rotation to avoid to stretch this painful piriformis muscle. Yes, for sure.
So your message is clear. AMG is the so we cannot this of piriformis syndrome without specific AMG done by someone like you, because I understand it's quite specific. So it's mandatory.
So it's mandatory for this kind of crime for different reasons. It's not 100% sure that this EMG will assess the positive diagnosis of piriformis syndrome, because it's only based on this H reflex. And this H reflex, it's not perfectly sensitive. That's sure. And it's not perfectly specific. And even if you don't have, because many times we cannot record any H reflex for different reasons. This H reflex, it's only the objectification of the Achilles reflex. So in some people, they are born without this S1 reflex, Achilles tendon reflex. So when we don't have any H reflex, we cannot say anything. But the other interest of this EMG, it's also to exclude the radicular origin with paravertebral gluteus medius minimus denervation, that if you have it, you know that it cannot be a piriformis muscles, or if you assess that the problem is a compression at the fibular head. So there is different method to assess a little bit the level of the sufferance of the sciatic nerve.
I think it's important to mention that. Dr. Radu Peligora said the question. He said, good evening. If you have an epidural infiltration to treat a lumbar pain, can it be interfering with Piriformis syndrome symptoms?
First, epidural injection is not a treatment for lumbar pain. That's the thing. If we have to do an injection only for low back pain, it's because it's a facetogenic low back pain. So it's a low back pain coming from the facet, and we can inject the facet. Okay, but epidural injection, it's to treat radiculopathy. So friends,
I believe that you said that, but can it interfere?
Yeah, but for the others, they have to know that epidural injection is not for low back pain, it's for radiculopathy. So if we inject an epidural for radiculopathy, if the sciatica is coming from this radiculopathy, this root impingement, there is no contraindication and there is no modification of the relation between the sciatic nerve and the PM. Now, if you do an epidural and the sciatica pain is not coming from the spine, but is coming from the PM-SN relationship, for sure the epidural will not be efficient, but there is no consequence on the sciatic nerve of the PM.
No difference, no problem.
No.
I have two questions from Bernard Lallemand. First of all, I will go to the treatment because, you know, otherwise I will miss some. So first of all, on the medical treatment, which muscle do you inject with botulinum toxin and at which dosage?
So which muscle? The one that has been confirmed by the anesthetic diagnostic injection to be responsible of the impingement. That's as simple as that. And okay, historically we injected the piriformis muscles, but more and more we consider eventually to inject also the gemellus OI complex, which is more and more involved as cause of this sciatic nerve entrapment. How many toxin? Usually we use the toxin A, and the dosage is variable between 100 and 200 UI. And into the muscle under ultrasound.
Another question from Bernard, and then I will have another question about the treatment. What exactly are the structures that are released during neurolysis? And what is the time to consider that conservative treatment should be considered as failed?
So conservative treatment, 6 weeks. If you have failure after a good conservative treatment using the technique I was describing, you have to go to the next step, which is injection. Okay, so what muscle do we have to release? Release, and also don't forget the neurolysis of the muscles. The one which is compressing the sciatic nerve. So you have to base your decompression on the image, MRI, on the NMG if there is, but the NMG will not tell you if it's the piriformis or the gemellus OI complex. But also the ultrastructural modification at MRN could be useful, and also the diagnostic and therapeutic injection. If you have a relief of pain when you inject the gemellus OI complex, release the gemellus OI complex. And that's the reason why we more and more use the endoscopic surgical release, because with this endoscopic treatment, we can follow the sciatic nerve all along its trajectory to see where is eventually the compression with this diabolo effect and this edema proximally.
We see that very well when we do arthroscopic assisted repair of the proximal hamstring on the ischial.
Yeah, for sure.
Question from Didin. So two questions. One question, I will read the question as it is. In your opinion, what is the most effective and sensitive test for diagnosis of Piriformis syndrome and any pathognomic sign? So first of all, we go on the clinic. Mm-hmm. If you have to answer a take-home message, what is a pathognomonic sign? Which one is it?
So it's simple. The pathognomonic sign doesn't exist. There's not. So when you read the literature, always when we talk about Piriformis syndrome, we talk about exclusion diagnosis. It's as simple as that. So it's a combination of tests you have to use. You have to think about history, you have to do a clinical assessment, and you have to use different investigation depending on the result of the clinical assessment. But there is no pathognomonic sign or positive diagnosis with any technique. So I think the most useful first test at clinical assessment probably is the FAIR test, knowing that it's not a mechanical pain that you induce, it's the postural pain. So you have to maintain this FAIR position for at least 1 minute before to say that, okay, there is no buttock pain, there is no sciatic-like pain elicited by this position.
And so the question, again, but it's important to keep a good message and clear, what is the most effective and sensitive test for the diagnosis?
Again,
I mean,
under the study.
Maybe I misunderstand. Maybe it was only on the clinical side. I thought it was the question about the complementary, the imaging assessment or EMG. By the way, this is the question that I can jump on this question, for example. I would like you to tell us more about the MRI. Mm-hmm. Is it possible to have an absolutely normal sciatic on a very good quality MRI if there is a Piriformis syndrome, or do we have to use a 3 Tesla? What is your opinion about that?
I think that it depends on the intensity of the problem. If you have only a small irritation of the sciatic nerve, you can have very high level of pain distally in the sciatic nerve. Mm. So in that case, the NMG could be completely negative. The MRI could be completely negative. It will maybe show you some change in the relationship between the PM and the SN. Yes, but you cannot affirm the diagnosis only on this basis. That's the reason why if you do a clinical assessment with a FAIR test positive, with the other specific test positive, and if you use also this list of 12 criteria that gave us Michel, so it's a bundle of clues that together confirm or affirm a little bit more the diagnosis. I think that's the best to do. And in that case, use also the diagnostic injection. That's a good tool also, diagnostic injection. If you relieve the pain, on the buttock pain and the sciatic-like pain, only doing an injection in the piriformis, okay, you know what's going on.
Can we cut this muscle without any big side effect? Is it a very important muscle or not?
Yes, but first there is multiple external rotator muscle. That's the first thing. If you cut a muscles, it's like a strain. It's like a strain of the muscles. Okay, so if you have an accident of your muscles, you will heal. So it's a little bit the same here. And even the rehabilitation after this kind of decompression is very, very fast. The day after, the patient should be standing. And he has to walk as soon as the pain allows walking. So it's not a very, very big problem to release the sciatic nerve, cutting this nerve, this muscle. Otherwise, we will not do it. Or the orthopedic surgeon, because orthopedic surgeon...
We know that we surgeon, my question was... yeah, we know that because when we do a total hip arthroplasty with using a posterior approach, the piriform is the one that we should preserve, by the way. But if it is a little bit damaged, it's not a huge effect.
Not a big issue.
No, but knowing that we cut anyway the external rotator when we do the approach and we repair them if we can. Thierry, I think it was great. It was really a good way to, first of all, to remind the clinic and imaging assessment, EMG, and treatment of this so-called Piriformis syndrome. It was in the same time a good way to do a sort of current concept of how to manage the buttock pain with sciatica. And I hope people will enjoy that. I'm sure they will listen and watch your, because there are so many diagnoses that it's good to rewatch again to have all the complementary, the differential diagnosis. And if I understand your message, as a take-home message, it's we need to think about this syndrome always.
Think about it. And if you have any doubt about the origin of the sciatic nerve entrapment, go back to YouTube, see at this differential diagnosis list. Think also, go to this criteria list of Michel, because I think it's a useful tool and do the job.
And at the end of the, because it's a question from Tuba, and what is the exact role of physiotherapy in your armamentarium treatment?
It's the first step treatment.
The first step.
It's the first step treatment. Michel did the study for his PhD. After 6 weeks of this treatment, only physiotherapy treatment, there is around 60–65% good and very good result. Okay, this result is maintained after 12 weeks around 50%, yes, and the remaining 50 go to injection. But only with physiotherapy treatment, we have good and very good result in about 50% of the case. So for sure.
And I think it's a good conclusion. So yeah, we will remember.
Use it.
So for people who want to have more information, go back to this video if you want, which will be always available to our channel. Thank you again, Thierry. So now for this live broadcast DxBone forum, you know that we start every week because it was the exceptional break and the situation of the COVID lockdown, and now I know that people are going back to the normal activity progressively. So we will go to a different rhythm. It's every 2 weeks. So it means our next DxBone forum live broadcast will be in 2 weeks, and it will be with Bernard Allemand, that we, our specialist of hand surgery and upper limb, and he will talk about the topic that we love, because you have so many, and it's important to have the correct diagnosis and the correct management of the finger sprains and dislocations. So see you in 2 weeks. Thank you again, Thierry, and it was great. Thank you. Bye, everyone. Bye, everyone. Hope to see you in 2 weeks.
I will.